Well, we are going to get started. Thank you all for being here with us today and spending your lunch hour here with us. Just a couple housekeeping things before we get started. We do ask that you keep your microphone and your camera turned off while we're doing this presentation. It is being recorded, and we'll send out a copy of this recording to you in a couple days after this presentation. But we will be utilizing the chat and Q&A feature. So if you have any questions at all for Dr. Srinivas here today, feel free to put them in the chat or in the QA, and we have some dedicated time at the end to hit all of those questions. If we don't answer all of them, we'll send them out in an email with those responses. So again, put any and all questions that you have for her here in the chat, and then we'll send out a recording when it's done here today. But we're very excited to have Dr. Srinivas here with us today. She is a neurologist who specializes in strokes, working here at Providence. And so I'm just going to pass it off to you, Dr. Srinivas, and you can take it away.
Hi, good afternoon. Thank you all for taking time from your lunch hour to be here. I'm very excited to be presenting. This topic is very dear and close to me. This is the bread and butter of my practice. I really enjoy treating my stroke patients and being on this journey with them, helping them figure out and come out on the other end being smart and strong and not being a victim. And I love working with this community, and it's been a great 2 years for me since I started this job at Providence. And thank you to everybody for having accepted me as a part of their community and trusting me with their care. So today my presentation, it's called Be Stroke Smart, Awareness and Prevention. Sorry about that, a little glitch. Okay, so May, as we know, is the National Stroke Awareness Month, and there's no better time to learn about stroke. So basically, for the remaining of the hour, I will be discussing the signs and symptoms of stroke. How do we recognize stroke so we can take timely action? And then also some of the risk factors that it's very common, but not a lot of patients who have strokes understand that their risk factors could have caused them to have a stroke. So I will be discussing about stroke prevention strategies. And by the end of this webinar, you should be able to at least define what is stroke, define the symptoms, risk factors, and prevention of stroke, and recognize if somebody is having a stroke, what the next steps are. So basically, when a patient asks me, what is stroke, Dr. Srinivas? For me, I define it as a sudden onset of a neurological deficit caused by a blood clot or a bleeding in the brain. So there are two types of strokes. One is called an ischemic stroke, which is caused due to blood clot and lack of blood supply to a part of the brain. So when that part gets damaged or is at a risk of getting damaged, the patients have symptoms. The other is called a hemorrhagic or a bleeding type of stroke, which happens when the blood vessel ruptures and the blood kind of splays out in the brain tissue, causing brain tissue irritation and causing stroke symptoms. So again, as I said, it's disruption of the blood supply to the brain. And when there is lack of blood flow to the brain is deprived of oxygen, which eventually leads to cell death and damage. The two types, as I said, ischemic and hemorrhagic. As you can see in this picture, this is a blood vessel. And then this one where my arrow is pointed is kind of the narrowing of the blood vessel. And when that happens, there's a lack of blood flow or decreased blood flow, which causes damage. And the other one is the bleeding type, which causes extravasation once the blood vessel ruptures. In addition to these two types of strokes, another important phenomenon, which is very prevalent, under-recognized, is what we call as transient ischemic attack. So in the definition itself, it's transient. So it doesn't leave any permanent damage, but it does cause a transient or temporary interruption of blood flow to the brain that causes typical stroke symptoms, but they're not long-lasting, or it doesn't cause any permanent damage to the brain tissue. These TIAs, or mini stroke, should be taken seriously, as they can be a warning sign of stroke in the future. So these patients have to be seen in the emergency room. We have a scale that we kind of score the patient to categorize them as mild, medium, or moderate risk, mild, moderate, or high risk, and then triage them and treat them accordingly. So it's very important to be aware, even if it's transient, lasting for 5 minutes, medical attention should be sought after. So basically a TIA or stroke, in this picture, as we're seeing, this is a normal blood vessel. This yellow thing that we're seeing is what we call as the plaque or atherosclerotic or cholesterol deposition. This plaque can build up, and after a certain point, it can rupture, and this rupture or the clot can peel off from the blood vessel and go into the brain and cause symptoms. And another type of stroke is what we call as an embolus, which means that when this blood clot travels from in the bloodstream and goes to a different blood vessel and can cause stroke. For instance, if there's a clot in the heart, it can travel from the heart to the brain. That's called an embolus. That means that the clot originates somewhere else in the body and then it travels to the blood vessel in the brain. When we're talking about TIA, the embolus kind of breaks apart and then the normal blood flow is restored, and hence it doesn't leave any permanent damage to the brain. So what happens in the brain during a stroke? So as we know, brain is very important. It controls our movement. It makes us who we are. It makes us human. It makes us intelligent. It makes us social. It stores our memories. It's a source for our thoughts, emotion, and language. And apart from that, the brain also controls some of the very primitive functions like breathing, our heart, our digestion. And then for it to function in an optimal environment, it needs oxygen. And our arteries, which delivers oxygen-rich blood to the brain. And when this is disrupted, that's when the brain tissue suffers. So stroke is sudden in onset. There is some patients that are ticking time bomb where we know they have certain risk factors. They're not on maximal medical management due to various factors. So we know they are at a very high risk of having strokes. For the majority of our patients, stroke is sudden. It comes without a warning. The patient is happy, hearty, healthy, and the next minute they've lost their ability to speak and they're plagic on one side of their body. So it's almost always a sudden onset phenomenon. There is really no way to absolutely predict who is at risk for strokes. Strokes can happen to anybody. It can happen at any age. It's no more a disease of the elderly. It can happen to a 20-year-old, to a 40-year-old, and to a 100-year-old. So stroke, there are a large number of risk factors, but it can happen to anybody. So what are the signs and symptoms of stroke? How do you recognize if a patient is having a stroke? So that's what we'll be talking about next. This is an acronym. It's called BFAST. I am sure anybody who's worked in healthcare or anybody who's a patient or has had a family member who's had a stroke is quite familiar with this acronym. It was earlier called just the FAST, but then they added the BE to it because a lot of patients who suffer strokes in the back part of their brain, their balance and vision is mostly affected, which was not included in the initial FAST acronym. So this is the best way to determine if somebody is having a stroke. So we'll go over each of what the BFAST stands for. So balance. Balance, has the person suddenly lost their balance or coordination? Sudden onset of vertigo, imbalance, holding onto the wall and walking, feeling unsteady is a sign of stroke. Eyes, is the person experiencing any decreased vision in one eye or one half of each eye if they have any double vision? Face is when a patient smiles, is one side of their face droopy. Arm, you have to have them raise both arms. So if there's any slight drifting on one or the other arm, it is a symptom of stroke. Speech, is the patient's speech slurred or language is the patient speaking, having word finding difficulties, their gibberish speech, are they not able to understand and comprehend what the other person is asking? So these are some of the most common signs and symptoms of stroke. And T stands for calling 911. There is no second guessing when you suspect a patient is having stroke, because time is equal to brain. So every minute a treatment is delayed, there's about 1.9 million brain cells die. And for every hour that the treatment is delayed, the brain loses as many neurons as it does in about approximately 3.6 years of normal aging. That's why we emphasize to call 911, not bring the patient in any private vehicle, because the triage can take longer and the patient will not get the right care in a timely fashion. Patients with fewer long-term disabilities have a fewer long-term disabilities with rapid treatment at stroke centers. So I think someone is having a stroke. What should I do? Unfortunately, there's nothing bystanders can do on site to support our stroke patients. The most important thing you can do as a witness is call 911. Unlike when we have cardiac arrest, we can administer CPR. Unfortunately for stroke, there is nothing that we can do as bystanders except to pick up your phone and call 911 and tell them that the patient is having stroke. So what are the risk factors for stroke? What causes stroke? Stroke is the number 5 killer and a leading cause of adult disability in North America. So it is quite important to know and be aware of the most common, what I tell my patients is controllable or modifiable risk factors. These are risk factors that are under our control. We can take care of it. We can optimize it. We can work towards betterment. So I will be going over some of the most common cause that is prevalent in the population that we can take action and do something about it. So the most common risk factors that I see in my day-to-day practice: high blood pressure, atrial fibrillation, cholesterol, smoking, diabetes, poor circulation, lack of physical activity, and obesity. I will be talking about each of them briefly. I think it's important that we recognize these risk factors and learn what impact it has on our overall health and also in preventing stroke. So what is high blood pressure? It's so prevalent. It's one of the most common risk factor. In fact, high blood pressure is the most important risk factor for both ischemic or blood clot type of stroke and for hemorrhagic type of strokes as well. So it's just very important to optimize this very risk factor. So blood pressure is the force of blood against the walls of the arteries. It is recorded by 2 numbers. One is the systolic, this is when the heart muscle contracts, and one is the diastolic, which is the lower number, which is when the heart muscle rests between beats and it refills the heart so it can pump for the next cycle. So what is high blood pressure? So high blood pressure is when the blood flows with too much force and it puts a lot of pressure on the arteries. This excessive pressure on the arteries kind of stretches it beyond its healthy limit, and when this stretch happens, the body's automatic response is to put it into an injury healing mode. And when this happens, this injury leads to minor tears and scar tissues, and this leads to deposition of cholesterol, platelets, and this eventually leads to hardening or narrowing of the blood vessel and also plaque formation. Nearly half of American adults have high blood pressure or hypertension. Optimal blood pressure is less than 120/80, and it is important that patients and caregivers know their blood pressure numbers and how to manage your blood pressure. Just a few tidbits. The normal blood pressure is ideally below 120/80. Again, it's not like one size fits all. There are a lot of my patients, I would like their blood pressure to be a little higher. especially in my elderly patient population who have kind of lived with high blood pressure. I don't want to tweak too much and change it or drop it too low, because that can put them at a risk of having fainting episodes or syncopal episodes. So you have to titrate the blood pressure according to the patient's age, their other risk factors, and the type of strokes they've had. So there are multiple things that goes into it. Nevertheless, this is where we would like the ideal number to be. People with high blood pressure do have an increased risk of having stroke. At age 50, ideal cardiovascular health adds to life expectancy 5.2 years for men and 3 years for women. Controlling your blood pressure means 80% of strokes may be prevented. More than 1 in 3 American adults with high blood pressure don't know they have it. It's very important that you have your blood pressure checked and keep it in check by self-measuring at home and recording it. A lot of fancy Bluetooth stuff have now come in the market. So all you need to do is record it. It'll send it to your phone. And that way, when you go to your physician's office, you kind of have the numbers so that if they need to titrate any of your medications, they can go by what the numbers are at home and not what the numbers are in the clinic, because clinic can be stressful. A lot of patients, when they have acute illnesses, their blood pressure falsely elevates, and it's dangerous to treat those numbers because they're isolated and they're not necessarily where the patient lives. So it's very important that if you are diagnosed with hypertension, please take responsibility by doing a daily blood pressure check at home and bringing it to your doctor's office. So what are the blood pressure categories? So normal is less than 120 over 80, elevated 120 to 129, high blood pressure stage 1 is 130 to 139, stage 2 is 140 or higher, hypertensive crisis is higher than 180. So these are important things where we want to recognize this early and try to prevent stroke and cardiovascular diseases. Next, coming to smoking. Sorry. So we know that, sorry, I have to move a little bit. Yeah. So nearly 12 out of every 12 out of every 100 adults in the US currently smoke. And according to a nationwide analysis of stroke survivors in the US, 58.8%, and that's a large number of people, had history of smoking. So cigarette smoking damages your heart and blood vessels, making you susceptible to stroke. This happens because there's a lot of carcinogens and oxidative radicals that are released, and this can eventually lead to stiffening of the blood vessel. As we learned earlier, stiffening of the blood pressure, increasing the blood pressure can cause the stress on our blood vessel wall, and this eventually can lead to damage. When this damage happens, the body recognizes that it's time to heal, but this healing process is not necessarily good. It can be damaging, which eventually leads to narrowing of the blood vessel and strokes. Where you live matters. Smoking is more prevalent in the rural areas compared to urban areas. A study found that white adults living in rural areas had 62% higher smoking rates compared to white adults in urban areas. Similarly with Blacks and Hispanic population. On the other hand, Asian adults are 32% more likely to smoke in urban areas. The LGBTQ plus community may also be at a higher risk of smoking. And this could be due to unique physical and mental health disparities. And women who smoke and are using hormonal birth control pills are at an increased risk of cardiovascular disease. It's also important to know that vaping is also significantly harmful on our body, which I will be discussing in the next slide. So long-term use of smokeless tobacco can increase the risk of dying from heart disease and stroke. Vaping and smoking can cause a similar level of damage to the arteries as well. So more and more studies are now showing that even though the vape doesn't have nicotine, it still can do significant damage to our blood vessel. A question that I'm quite often asked in clinic when I discuss quitting smoking with my patients. And the next question is, can I vape? Because this is a habit and it's really hard to kick, especially if you've been smoking for a long number of years. Unfortunately, there is nothing that can substitute or help. I think they all carry somewhat comparable risks of significant cardiovascular health and stroke risks. Diabetes. Whether you're a type 1 or a type 2, diabetes is an independent risk factor for stroke. The risk of stroke is 2 times higher when you have diabetes. Unfortunately, most of these patients are overweight and have other comorbidities as well. And it becomes more pertinent to be recognized and treated and make sure you're going in for your checkups and you're checking your hemoglobin A1C, making sure you're checking your fasting blood sugars at home. This way, it can decrease the risk of strokes. So briefly from the Heart Foundation, diabetes is a condition when there's too much glucose in the blood and we don't have enough insulin that's able to kind of break down the glucose. People with diabetes are 2 to 4 times more likely to have a heart attack or a stroke. Another important thing, diabetes can also cause what we call as silent heart attacks. And in some of our stroke patients, it can cause silent strokes, which means that we are able to see the damage on the brain tissue when the patient has an MRI or a CAT scan for other reasons, but they don't necessarily have symptoms. But this also tells me that they're at higher risk of having strokes where they can have symptoms. Diabetes does speed up heart disease. Although it says heart disease, the pathology or the way the stroke happens is about the same. As you can see in this picture here, this is a normal blood flow cross section. There's blood flowing, and with patients who have diabetes, there is this plaque buildup, and it can happen faster, and this plaque eventually leads to peeling and distally going into the brain or causing narrowing and significant decrease in blood flow. Diet. Everybody talks about diet. It's become a whole, it's a whole business because there are a lot of wellness programs now, a lot of dietary programs. People are more interested in understanding how much a diet can do to a person's health. And there's a lot of the carbon footprints that is in talks. People are more aware of what they're putting in their mouth because it makes a lot of difference, not only to our health, but our overall longevity as well. As we all know, diets which are high in saturated fat, trans fat, and cholesterol can significantly raise our blood cholesterol levels. Those high in sodium, those that are high in high calories, especially the ultra processed food that we get. You know, we're all looking for easy ways. We're busy people. We want to get something in our tummy, just get that energy and going. But just buying those few minutes in a day by getting something from the store and putting in the microwave versus spending 15 to 30 minutes in the day making your own home cooked food adds more value and age, which is under-recognized and underappreciated, but I think it goes a long way and it's very, very important. A diet containing 5 or more servings of fruits and vegetables per day can reduce the risk of stroke. There are 2 types of diet that are recommended by the American Heart Association. One is the very popular Mediterranean diet. The other one is the DASH diet, which is not as well discussed, at least in my world, which is dietary approaches to stop hypertension. Both these diets have significant benefit on the overall health and well-being of individuals, not necessarily patients alone, but even caregivers, even us who are otherwise healthy. These 2 diets have shown significant benefit. So basically, both diets typically aim for 2 servings of fruits and 2 servings of vegetables. Substitute oil for unsaturated fats or olive oil and spread. Limit sodium intake to less than 2 grams a day. You know, you obviously want to add salt to your food, but I think avoiding that added salt on top of what you already have is going to be very important. A good source of protein: fish, eggs, soy, tofu, a lot of plant-based protein milks that have come out. So they're all pretty healthy. The only key difference is the Mediterranean diet includes a higher intake of healthy fats and fish, less dairy and moderate consumption of alcohol, whereas a DASH diet allows more dairy products and meat products. So that's the only difference. A plant-based vegetarian or vegan diet can also be pretty healthy. Physical inactivity. We all have smartwatches. We all want to get the 10,000 steps. It's a great feeling. If you have an Apple Watch, you want to close all your move rings, because when it hits that 12 out of 12, it's great. I've sat in flights and patients are just like, not patients, people are just like rolling their arms just so that they can get that move ring going. So it's pretty interesting how these things have kind of subconsciously creep their way into our lives. And I think for the good or bad, it's there and it's here to stay. And I think we should make the most of what we have. So as we all know, physical inactivity can increase your risk of stroke, heart disease, overweight, being obese, high blood pressure, cholesterol, and diabetes. We have 24 hours in a day, but between juggling and doing multiple things, we might not get as much time to give in a dedicated 30 or an hour exercise. So basically, the American Heart and Stroke Association recommend at least 30 minutes of moderate intensity aerobic exercise for 5 days a week. So that counts up to 150 minutes. And this is something I tell my patients. So whatever I'm talking here is entirely based on my experience with my patients. You don't have to start big. We all have to take those one small step. Even if you cannot do 30 minutes from the get-go, divide it into 15 dedicated segments. You want to do cardio in the morning? Great. 15 minutes of walking on the treadmill, stationary bike, taking a walk around the block, just getting your heart rate a little up. And in the evening, you can do 15 minutes of either a fun aerobic exercise, a dance routine, lifting weights, something where at least you get 30 minutes of some form of moderate intensity exercise, or at least 25 minutes of vigorous aerobic activity for 3 days a week or 75 minutes. So this can be those high intensity workout. You can go sit in a sauna. That also helps burn calories. So there are multiple things that we can do to incorporate physical activity in our day-to-day life. And you can also combine either or with a moderate high intensity exercise with muscle strength activity for at least 2 days a week. Muscle strength is a great form of exercise. I personally feel we should all incorporate this into our life, especially women, because once we hit the menopause, our bone strength, bone density, muscle mass, everything goes down, and it can just not make it, it just can make it hard. So I think incorporating bone weight training early on, like in our 30s and 40s, is going to do us a great deal of good when we are 60 or 70. All you need to do is 3 days a week, pick a muscle group and just focus on that, and it will go a long way. Obesity. So we all know excess body weight, and it's linked to a multitude of diseases. Even losing as little as 5 to 10 pounds can significantly affect your risk factors and your risk for having a stroke or heart attack. Even if weight control has been a lifelong challenge, taking small steps to manage your weight can significantly lower your risk of many comorbidities. Some of them that are listed here: type 2 diabetes, your blood pressure, cholesterol, heart disease and stroke, sleep apnea, fatty liver disease, cancer, and gallbladder disease. So weight is a very important aspect. Another thing that's not as emphasized is abdominal fat or the abdominal girth. That's what we usually measure to kind of tell if the patient qualifies for what is called as a metabolic syndrome. And if their waist inch is above a certain number, it's not really healthy. Apart from all this that has been mentioned in this slide, something that's not as well discussed or made aware of is some of the medications. In my practice, aspirin, for instance, I prescribe, my husband calls me an aspirinologist because that's what I do as a stroke provider. aspirin can become resistant in patients who are obese. So that's something that's very important to know and not discussed as often. So it's just, we have certain doses of aspirin and we don't really prescribe high doses based on body weight in all our patients. But nevertheless, it's just very important to know that aspirin can be resistant or not as effective in patients who are obese. And in patients who are not diabetic, obesity puts them at a risk for diabetes because the insulin that's secreted in our body that prevents us from developing diabetes can also be resistant in patients who are obese. So these are some important things to note. Cholesterol, as we all know, high cholesterol increases the risk of blocked arteries, as we are able to see in this nice picture. This is the normal artery. Then the fatty streaks start developing. Usually it's around 25 years old. That's when there's a slight fatty streak that develops in all our blood vessels. And if we are cognizant of our health, taking care, have an optimal health where we are controlling our risk factors, recognizing them, we obviously want to try to halt it at this stage. But if that doesn't happen, this can eventually lead to plaque. The plaque builds up and this leads to a blocked artery. In some instances, if the artery is fully blocked, then there's not much else we can do, especially the arteries that are going to the brain. So we want to make sure that we are aware of why we are emphasizing you have to take your statin, you have to exercise, you have to cut down on certain kind of food, because we want to kind of halt this process. Because once this plaque develops and it blocks it, there are stuff that we can do, but in most cases, there's not much we can do. So that's why it's just very, very important. In a stroke world, when we talk, there are different parts. This one is cholesterol, one is triglycerides, one is the bad cholesterol, which is the low density lipoprotein, and one is the good cholesterol, which is the high density lipoprotein. So when I prescribe a statin to my patient, I'm mostly focusing on bringing down their total cholesterol and their low density lipoprotein, because this is what is implicated as a risk factor for stroke. And that's why I'm checking those levels and titrating their medications according to that. Atrial fibrillation. It is a quivering or irregular heartbeat or arrhythmia. The heart has 4 chambers, so this kind of originates from the left upper chamber. Over 12 million people are projected to have AFib by 2030. So what are some of the common symptoms that the patient can walk into clinic and you would think that, oh, this could be atrial fibrillation. So my heart flip-flops, skips beats, feels like it's banging against my chest wall, especially if I'm carrying stuff up and down the stairs or bending down, feeling nauseated, lightheaded, and weak, had a really fast heartbeat, and I was gasping for air. And the patients had no symptoms, and then they discovered they had atrial fibrillation at a regular doctor's checkup. So what happens during AFib, and why is it so important? Why is it that when patients whom we don't have cause of stroke at the initial visit, we are looking aggressively for atrial fibrillation? So basically, when our heart contracts and relaxes to a regular beat, in AFib, the upper chamber of the heart beat irregularly, and because not enough blood is being pumped out of the atria into the ventricle, so the blood kind of tends to pool there. And when this pooling happens, our blood is really viscous, so it has to keep flowing. And when it doesn't flow and it becomes stagnant, the blood tends to form clots. And eventually, when this clot goes from the upper chamber to the lower chamber, it can get dislodged into the bloodstream and eventually goes to the brain and causes stroke. About 15 to 20% of patients who have stroke have atrial fibrillation. And an untreated atrial fibrillation is associated with a 5-fold increased risk of stroke. And this is a very treatable condition when recognized. We do prescribe blood thinners. The whole point of blood thinners is to kind of break that clot away, so that we minimize the risk of patients having stroke from that. Sleep apnea, another quite common pathology that's prevalent in our population. Sleep apnea increases the chance of stroke by 60%. The condition can impact people of all ages, including children, but the risk factors include being male, overweight, and above 40. More than half of the people who have stroke also have sleep apnea. The most common signs and symptoms, snoring, usually observed or reported by a sleep partner, disrupted sleep, waking up frequently in the middle of the night, gasping for air, daytime fatigue, morning headache, poor concentration. Why is it important to recognize and treat sleep apnea? Is sleep apnea does increase the risk of high blood pressure, can make patients who already have a diagnosis of blood pressure more resistant to treatment. And it's one of the most common causes for atrial fibrillation as well. So it's very important to recognize and treat sleep apnea. So these are some of the problems that sleep apnea or untreated sleep apnea can cause. So it's very important to recognize the signs and symptoms and seek care from your provider so they can make appropriate referrals and the patient can be treated. Carotid artery disease. So carotid arteries are two major arteries that we have the heart, then we have the aorta. The aorta gives rise to two arteries. One is the left carotid artery and the right carotid artery. So the carotid artery is the one that gives blood supply to the front part of the brain or the anterior part of the brain. So carotid artery disease is very, very common in the population and one of the most common causes of stroke, which can be recognized just by a stethoscope, because when we have plaque in the carotid arteries and you go to your primary care provider and they're like, okay, let me check your neck, and they hear for what is called as a bruit. A bruit is a turbulent flow of blood through a narrowed segment of the carotid artery. So again, this is a disease that can be recognized just by using a stethoscope. So it's very prevalent, easily recognized, and can be treated if managed in a timely fashion. So carotid artery disease is responsible for up to 1/3 of the strokes. It can cause a debilitating or deadly stroke if untreated. Again, as we discussed in all the previous slides, it is still a blood vessel, so it kind of has the same fatty deposit, clogs the blood vessel that deliver blood to the brain and the head. This condition develops slowly and results in a narrowing of the arteries, increasing the risk of stroke. There are often no symptoms, and the first sign of a carotid artery disease is usually a transient ischemic attack. And the most common symptom of that is transient loss of vision in your eye, what we call as amaurosis fugax. So basically, the patient feels like a curtain-like sensation in front of their eye, and they lose vision. It's transient, 15, 20 minutes, and the vision comes back. Usually, it's a painless phenomenon. And then when they seek attention, that's when we scan and look like the carotid artery is blocked. So again, as I said, regular checkups are important. Your healthcare professional can listen to the arteries in your neck with a stethoscope for abnormal sounds, or what I called, it's called a bruit. I'm not going to go much into the details of this. It should be available when they send out the slides, but I think it's a very, very important pathophysiology to recognize and be aware of. Some of the other risk factors for stroke are peripheral artery disease, similar to the disease in the heart, similar to the disease in the neck. It's basically narrowing of the blood vessel in the leg and the arm. So the same fatty buildup happens, and patients have what we call as claudications. Every time they walk, they have this throbbing pain in their leg, and then they do an ultrasound and find that they have narrow arteries. The treatment is pretty similar, but there are slight differences as well. But patients who have peripheral artery disease are at a high risk of having strokes as well. Coronary artery disease, heart failure, dilated cardiomyopathy, heart valve disease, and congenital heart defects are also some of the most common risk factors for stroke. Now, those were what I call as modifiable, and there are some risk factors that are not modifiable. So what are those risk factors? So first is age. Strokes can occur at any age. As I said, 1 out of 5 people who have a stroke are under 55 years. But the chance of having a stroke obviously increases as we're getting older. even babies and children can have a stroke, although they might have different mechanisms as to why they're having a stroke, but nevertheless, they can have strokes. Next is race. African Americans, Hispanic, Asian Pacific Islanders have a higher risk of having stroke. And this could be just due to the genetics, their risk factors, and also the kind of societal barriers and systems that have kind of harmed how they look at medical care over the period of years, have all contributed to an increased risk of having strokes in certain races. More women have stroke than men, and more women die from stroke, including than from breast cancer every year. In the next slide, I'll discuss why women are at a risk, because I think it's important to recognize that. Family history, you are at a greater risk of having a stroke if you've had a family member, especially if there's a genetic predisposition to having a stroke. Another important thing is a person with a prior history of stroke has a much higher risk of having a stroke, and a person with one or more TIAs is almost 10 times more likely to have a stroke than someone of the same age and sex who hasn't. So that's why it's very important to recognize those transient symptoms and seek medical attention at the earliest possible. So women have more strokes than men, and strokes kills more women than men. There are several risk factors that kind of put women at a higher risk. So pregnancy and preeclampsia. So pregnancy does a lot of changes to our bodies, and some of these changes can make women put them at a higher risk of having strokes. Pregnancy can also lead to blood clots in the venous system of your brain as well. So that's an important thing to recognize. Preeclampsia is basically pregnant women who have high blood pressure. And this can eventually lead to eclampsia and seizures and strokes. So it's very important to recognize that early on. Birth control pills, especially those containing estrogen, and even hormone replacement therapy, which is given to postmenopausal patients with premature ovarian failure, patients with premature hysterectomy. So those who need supplemental estrogen, they can be at an increased risk of having strokes, because it kind of forms blood clots. And this blood clot, as I discussed in the earlier slides, forms an embolus, and that kind of travels through the bloodstream into the brain and causes stroke. Migraine with aura, and especially if they have an additional history of smoking, and atrial fibrillation. It's more common in women than men, especially after the age of 75. So just some facts. About 55,000 more women than men have a stroke each year. Stroke is the number 3 cause of death in women and number 4 cause of death in men. So number of stroke deaths in the year, if you're able to see this one here, it's over 77,000 in women. So just have to be aware. That's why it's very important to recognize and know what the signs and symptoms are. So no matter what age, race, gender, we are all at an increased risk of having strokes. This is my favorite. So I trained in the stroke belt area of the country, and I had my uncle is like, where do you want to take up a job? And I was like, I want to go to the stroke belt because that's my bread and butter, and that's where I wanted to practice. So it is called the stroke belt. It's basically because the highest death rates from strokes are found in the southern eastern United States. As we are able to see in this graph here, the stroke belt, which is in the beige color, Arkansas, Louisiana, Mississippi, Tennessee, Alabama, Georgia, South and North Carolina. And then there's a stroke buckle, which is just adjacent to that, but they're all in the southeastern area of the country. So there is a 3-year life expectancy gap between rural and urban population. Rates of physical inactivity, obesity, tobacco use are all higher in the rural areas. And some of the other reasons why strokes are more prevalent in these rural areas are racial differences, socioeconomic status, quality of healthcare. Stroke fatality rather than stroke incidence is elevated, prevalence of stroke risk factors, lifestyle choices, genetic factors and infection rate as well, which can contribute to the fatality. Living in the stroke belt, so 13% higher risk of stroke than living elsewhere in the United States. live in the stroke belt as a child or teenager, 22% higher risk of stroke compared with people who move to stroke belt as adults. So it's just interesting, but this is actually the stroke belt of the country. Alcohol, again, very standard question that I ask: can I have a glass of wine? Can I drink beer once I've had a stroke? What are the risks of having another stroke? Alcohol abuse can lead to multiple medical complications, which also includes stroke. So basically, the American Heart Association recommends no more than 2 drinks per day for men and no more than 1 drink per day for non-pregnant women. So standard drink is 375 ml bottle of mid-strength beer, 100 ml of wine, and then 30 ml of spirit. So this is usually what I tell my patients in clinic as well. So this is what I practice. As long as you're maintaining this, you're not binge drinking. It's not like you're not drinking for a week and then on the weekend you're binge drinking. It's not the same. So binge drinking can be quite harmful to our health. So this is what I recommend following. Use of illegal drugs and highly addictive substance, very, very common. We're seeing a lot of patients these days. The most common ones that are implicated in stroke, cannabinoids, methamphetamine, significantly increases blood pressure. It can cause both bleeding and clotting type of stroke. Cocaine use can cause bleeding type of strokes. Mixing prescription drugs, especially those with pain relief, used for pain relief, can also pose an increased risk of stroke. So it's just very important to recognize that drug interactions and strokes, drugs can cause stroke. So it's just very important to recognize this, seek medical attention. If you know somebody you love doing it, please seek medical attention. Because addiction is one aspect of it, but the other complications that can come with that is pretty devastating. So we're at the end of our slide. So stop stroke. So stroke prevention, 80% of strokes are preventable. Yet stroke remains a leading cause of death and serious long-term disability. So why is that? I think what it boils down to is just education and understanding, meeting with your provider, knowing what can I do for the betterment of the health of my health, being an advocate for your own health. So these are all important, and they really go a long way in preventing strokes. Knowing your risk factors. If you have type 1 or type 2 diabetes, making sure you go for your checkups regularly, making sure you take your medication, stick to your regimen, making sure you get your fasting blood sugar every day, making sure it's in range. High blood pressure, as I discussed earlier, make sure you document your blood pressure readings at home every day. That way, when you go to the doctors, they can kind of tally it and adjust your medications accordingly. Not smoking, and smoking is a very hard habit to kick. I've heard this time and again with my patients. So something that I've started implementing in clinic that has kind of worked is telling them, coming to bargaining terms, I know you cannot quit cold turkey, but setting an alarm to smoke is something that I've been testing and trying in clinic. And so far it seemed to work, where I tell them to set timely 3-hour alarm where they can pick up a cigarette, and that alarm has to go to 4 hours, 5 hours, 6 hours, and eventually cut it down. And there are a lot of resources available as well, but it's so important to stop smoking. Not only does it cause strokes, in those who've had strokes, it can delay the whole healing process. 30 minutes physical activity each day, good healthy diet, and maintaining an ideal body weight, at least if not ideal, a healthy body weight. So pretty repetitive, but it's just very important to recognize all of this and educate you and your family members. So there are 3 types of stroke prevention. One is primary prevention, which is screening for pre-existing risk factors. Secondary prevention is what we do call medications, and then tertiary prevention is individualized care for each of our stroke patients based on their risk factors and other health comorbidities. This is kind of a prevention checklist, which I think it's great to have and circulate among people you know. The last one is, I think I want to talk about this slide. So empower others to react, not regret. If you suspect a loved one may be having a stroke, please call 911. Urgency is the key. Hesitation and fear cost time. it's not going to take much time to pick up your phone and dial. Stroke is a wolf in sheep's clothing. Signs and symptoms can be subtle. So it's very important not to think too much or analyze too much. We don't expect you to be medical professionals, but even if there's subtle signs and you feel like, okay, this is a stroke, please call 911 and please spread the word so we can all join force and reduce the risk of stroke and disabilities from stroke. So that's all I have for you folks today. Thank you.
Awesome. Thank you so much, Dr. Srinivas. You've got great information, such important information. I've got lots of questions here for you. I'm going to try and hit all of them. But just the first thing that I will say, you talked a lot about great prevention strategies, blood pressure management, tobacco cessation. Our office here at Providence Community Wellness, we offer lots of those things. We offer blood pressure self-management and tobacco cessation and weight management, all those fun things. So if any of you have any questions specifically about those, I just put in our email and our phone number in the chat, and I'm happy to chat with you about any of the other programs that we offer specifically for that. But questions for you, lots about some blood pressure here. Someone is asking, what are some symptoms of high blood pressure?
So some of the symptoms of high blood pressure are headache and blurry vision. They are the most common. Some patients can have confusion. They can have loss of vision because if there is high blood pressure, just like the arteries in our neck and head get affected, the arteries in our eyes also can harden over a period of time and can rupture. But the most common symptoms are headache and blurred vision.
Can you have hypertension for the rest of your life, or can it be resolved?
That's a good question. I think once you're diagnosed, that's why it's important once you're diagnosed with hypertension, we usually leave patients on blood pressure medications, more so in the younger ones, because ideally you should not have hypertension as a younger adult, but if they have been diagnosed, we do tend to leave them. In older adults, we mostly titrate them based on their symptoms. So yes, you will have a diagnosis of hypertension for the rest of your life, but then you don't necessarily have to be on medications, and that's why we ask them to kind of document their numbers so we can titrate, make sure they're not being overtreated or undertreated.
You talked a little bit about specifically for women and how estrogen can play a role in this. Someone has a question here. Does your stroke risk increase with the use of estrogen during menopause?
Yes, it does increase the risk of stroke. We don't have clear-cut data on who is at risk and who's not at risk. But the longer, suppose you're at menopause at 50 and you start estrogen sooner than later, your chance of having a stroke is much reduced than starting it at a later time. The estrogen, the hormone supplements are most commonly now seen in the younger population, especially with gender change. That's when they are taking not FDA approved stuff online. We don't know what the hormone contents are. So these patients are much more at a higher risk of having strokes due to hormone supplementation. So it's very important to talk to your provider, the risks and the benefit, knowing what your previous stroke risks are. So these are important things to consider before starting estrogen or hormone supplement.
Thank you.
You can use creams, so there is no risk for doing creams.
Okay, great.
Yeah.
I've got one question in here. It's a bit specific to them, so I'm not sure if you'll be able to answer this one, but they said, my lower blood pressure is mostly in the 50s. I take metoprolol 25 twice a day. Is this okay?
As long as you're not having symptoms of any pre-syncope, which means lightheadedness, fainting spells, when you're sitting and standing, you don't feel like woozy. If you're not having those symptoms, it's fine. We titrate medications, and everything we do is based on the patient's symptoms and risks. So yes.
Great. A question here, we talked about some tobacco cessation. Are we talking just cigarettes, or is an occasional cigar smoking an issue?
Cigarettes. Okay, cigar smoking is still allowed, but not on a daily basis.
Okay, the occasional that he's asking. Okay. And then I've got one more question that I'm seeing here. Again, if anyone else has any others, feel free to put them in the chat. But the last one I'm seeing here is about fastest time for hospital arrival for stroke confirmation. And they said, who has the fastest time from hospital arrival, stroke confirmation to TPA admit? Is that Providence or Multicare?
I can't answer this question. I'll be so biased. The thing is, Multicare is what we call as a primary stroke center, which means that they can administer altiplase, but they don't have the capability to mechanically go pull the clot if the patient has a large blood clot sitting in their blood vessel. Holy Family is also Providence, and they are what we call as a primary stroke center. So they have the ability to administer altiplase. But again, if there is a clot, the patient has to be transferred to Sacred Heart to pull that clot out. So it all depends on how soon the symptoms are recognized and the patient presents to the hospital.
I think just keeping in mind, if we notice those symptoms that you just talked about, that we, call 911 and that's that first.
Yes, please call 911.
Another question in here, talking about secondhand smoke. Does secondhand smoke also increase your risk for a stroke?
Absolutely. Smoking spares no one. It's just like, no. So secondhand smoking is not any better than primary smoking. Yeah.
Another one in here, you discussed ischemia based on blood clots. What percentage of stroke is fat emboli, septic emboli, or cholesterol related emboli?
So septic emboli is not as common. So septic emboli patients are like 1 or 2%. So the plaque emboli is 85%, the blood clot. And out of that, 15 to 20% can be from atrial fibrillation. The remaining can be intrinsic or from the blood vessel pathology itself. So 85% of the population suffer from ischemic stroke, and the 15% is bleeding type of stroke or hemorrhagic stroke.
These are great questions. I love that they keep coming. We've got another one in here. How about Parkinson's patients? Are Parkinson's patients at increased risk for stroke?
No. But a stroke, if it affects a strategic location in the brain, it can cause Parkinson-like symptoms, but Parkinson patients as such are not at an increased risk of having strokes.
Great. Well, I think that's it. I think I've hit all the questions here. So thank you again, Dr. Srinivas. That was so great and so informative. We are done here for the day. If anyone has any last minute lingering questions, we'll hang out just for a couple more minutes. But otherwise, thank you all so much for being here with us. And we'll send you an email of this recording as well.
And yeah,